Okay. Good morning. Is it so? Yes, it's good morning. And I welcome you to our Community Research Academy program this morning. We have Dr. Paul Christos, and he's come and he's going to discuss with us and talk to us about biostats, how to communicate with the biostatistician when performing clinical research. I'm just going to give you a little information about him. Dr. Christos is the Director of Research Design and Biostat here at the CTSC. In his role as director, he's the administrator of the program, and he has the ongoing responsibility of developing, organizing, evaluating, and teaching courses, mentoring junior investigators, writing protocols and proposals, reviewing protocols, developing new statistical methods applicable to translational science, providing analysis of data for projects through the Research Design and Biostats core. He has a doctorate of public health and epidemiology, which he got in '09, a master's in biostats and a master's in public health in epidemiology in 1995, all from the New York Medical School of Public Health prior to joining Weill Cornell Medicine. And he joined in 2000. So here, the next voice that you will hear is Dr. Paul J. Christos.
Thank you. Thank you, Lil. I appreciate that. I'm sure we'd rather be watching the election results versus a statistics talk, but it's good to take a little break, I guess. So as Lil was saying, I run the Biostatistics, Epidemiology, and Research Design core of the CTSC. So it's basically a component of the CTSC grant that we have at Weill Cornell that essentially works with investigators, clinical researchers to help them design studies, help them to collect the data from those studies, help to analyze the data that typically would come from those studies. So what I'll talk a little bit about today is just how to interact with a biostatistician in the context of a clinical research project. And I'll go over some examples of the types of things that we typically do with the studies that we're working on. So essentially, if you're doing a clinical research project, obviously you have an idea. That's more of the design phase of the project. You then the best thing to do would be to reach out to some type of a biostatistician at some point early in the development of your study. And then the statistician typically becomes a member of the team, of the study team. And then once the data is ultimately collected, the statistician will be involved in analyzing the data, helping to present the findings, helping to write up the manuscript or the abstract, whatever you might be doing for the research project. So R.A. Fisher was a famous statistician back in 1938, and this is just a quote from him: to call in the statistician after the experiment is done, maybe no more than asking him or her to perform a post-mortem examination. He or she may be able to tell you what the experiment actually died of. Meaning that if you bring in the statistician after the project is done, after you've designed the study, you've collected your data, you have the data, let's say, sitting in an Excel file somewhere, and then you call in the statistician after the fact, it could be pretty bad because maybe the data was collected incorrectly and it won't really be able to be analyzed in the correct way. So it's always good to have the statistician involved very early on in the project. So at the core, the Biostats Epi core at Weill Cornell, we like to encourage investigators to reach out to us very early. And if anyone has any questions, feel free just to interject at any point. So typically, if you have a clinical research study, you're obviously going to have some kind of a study protocol that you're drafting or writing. And if you're meeting with a statistician early on, it's good to send those materials in advance, obviously, to the statistician. So that would include the study protocol, the measurement instruments. So if you're measuring, if you're administering a survey and you're asking about exposures or risk factors for a certain disease, those measurement instruments that you would be collecting the data, it would be good to send that to the statistician early on to have their input. Any kind of relevant background literature on the topic or the medical topic that you're looking at. Is there some existing data sets that already exist in terms of having that data? Or if you've collected some preliminary data, you could send that to the statistician as well. So the statistician obviously is not an expert in the clinical area that you're researching. So it's good to kind of give them a layperson's exposure to the topic. So explain the clinical terms that are relevant to the study. They're obviously not going to know all the medical terms, for example, that you would know. So it's good to be patient. The statistician typically will ask a lot of questions to understand the clinical area. A lot of what we do is we try to match the statistician to various clinical departments. So we have about probably 18 or 19 master's level biostatisticians at Weill Cornell that typically will work for some designated amount of time with various clinical departments like radiology, anesthesiology, cardiology. So if we embed a statistician within that department or that division, they kind of become an expert, or they learn more about that subject area. So that's really the best way to do it, because then the statistician becomes knowledgeable about that topic. But more often than not, they have to work on many different things at the same time. So through the CTSC Corps, for example, we'll get numerous requests from many different groups. So the statistician obviously is not going to be an expert in all those different areas. So it's a lot of kind of learning, and they will try to have a very deep conversation with the clinical investigator to understand the topic. So from the investigator's standpoint, if you're meeting with the statistician, you don't want to jump around. You want to have, very specific aims to your study that you can explain one at a time to the statistician so they can help you. So it's really good if you're designing a research study, and maybe you've talked about this earlier in the course. What is a research question? So typically you want to have a clearly defined exposure, a clearly defined outcome, and what's the population you're looking at. So is risk factor X associated with the change in Y in population P. So X would be the risk factor of interest. Maybe you're doing a study looking at the effect of high-fat diet on colon cancer. So high-fat diet is your exposure of interest. Y would be your outcome, such as colon cancer. And then your population is really, who are you studying? What's the inclusion criteria for your study? And you want the question to be SMART, which is just an acronym. So basically, is it specific? Ideally, with a research protocol, you want to have one or two primary objectives. Is it measurable? Whatever you're trying to ask, is there a quantifiable endpoint that you can measure? So if you're looking for example, a reduction in cholesterol over time, that would be your endpoint. Is it easily measurable? Is it attainable? Do you have appropriate resources to measure it in terms of feasibility and cost? Is it relevant? Is it novel? It doesn't necessarily always have to be novel. If you're collecting preliminary data or you're doing a small pilot study just to get some information. Is it clinically meaningful? What's the difference you're really trying to detect? What's your hypothesis? And ultimately timely, how long will the data collection take? How feasible is it depending on your resources? So bad research questions tend to be very vague, they're unfocused, they're not really quantifiable, and we'll see a couple of examples. Obviously, a good research question is very specific, very focused. It has a very quantifiable endpoint. So here's an example. What would be a bad research question? Or not so much bad, just not very specific. So for example, is radiation therapy helpful or harmful? So obviously, if an investigator came in to meet with a statistician and they said, I'm doing a study on a particular type of radiation therapy, I want to know if it's helpful or harmful, that would not be your primary aim in the protocol. The actual primary aim might be very specific. Is there a difference in overall survival? Overall survival would be your endpoint between stage 3A non-small cell lung cancer patients who receive postoperative radiotherapy versus those who do not. Sorry, my screen is blocked here. Versus those who do not receive postoperative radiotherapy. So you're being very specific. You're comparing two groups of people. Your population of interest is those that have stage 3 non-small cell lung cancer. Your endpoint of interest is overall survival. The one up here is a very general statement, but you really want to have a very refined research question. And that's what you would want to walk into the statistician when you meet with them, so you can tell them that's exactly your question. The types of things we work with in terms of the outcomes and the exposures that you would want to talk to the statistician about. Are your endpoints continuous? What are you measuring? Is it change in blood pressure, cholesterol? Is it a binary type outcome, such as they have a recurrence, yes or no? Is the outcome ordinal, meaning are you measuring like something on a scale, like let's say a pain scale is your outcome, and it goes from 1 to 5 in terms of pain? So that would be considered ordinal. Nominal would just mean, typically categories that have no ordering to them, for example. Then you want to identify possible confounders. These are variables that typically might mess up your results. So if you're looking for if your study is looking at the relationship between high-fat diet and colon cancer, a confounder might be a variable that would get in the way. So you'd want to control for things like age, gender, other comorbidities, other variables that might impact colon cancer that have nothing to do with the high-fat diet, for example. So those are called confounders. So that comes from the clinical knowledge, that comes from the literature. So these are all things you would bring to the meeting with the statistician, because you really want them to be part of your study team. When you collect the data, many times we'll get data from investigators kind of mid-study. So maybe the statistician was not involved from the beginning. So you want to avoid, how you send them the data, for example. So, avoid language such as column AE. So for example, they'll send us an Excel file. It'll have a bunch of columns in it, column AE. We want to look at column AE and do something with that. You want to avoid that. You want to have very specific medical terminology. It's good to have a data dictionary, they call it, where whatever study you're doing, you just have a kind of a code book that tells everybody all the variables you're measuring. If you're going to send them an Excel file or some kind of file with the data already collected, just have everything labeled very clearly. It's good to have this data dictionary that tells you all the possible values the variables can take on. If it's a categorical variable like race, ethnicity, just have everything defined in the book. You might have a coded 1, 2, 3, or 4, but just have a code book that tells you what all the codes mean. You want to avoid ambiguity. So for example, if you're entering dates into the file, let's say it's, date of surgery, date of relapse for a certain disease. You want to have a standardized format. You don't want to enter things kind of different every time. You want to avoid, free text responses. So if you're collecting data on some outcome and maybe the response is negative or positive, you just want to have a common, obviously, way of entering it into the file. So you don't want to have 0, 0 neg, because you really can't analyze this type of data because it's too much text in the file. You probably would want to code it as 0 equals negative, 1 equals positive. Just kind of have a standardized format. So typically you want to avoid free text in your data files that you would ultimately send to a statistician. And obviously, if it's a focus group study or it's very preliminary or you're doing a survey, you can have free text, and just for your own knowledge of collecting the data, that's fine. But when you send it to the statistician, you want to clean it up and have it more uniform. So in terms of data sets, how we collect the data, there's a couple of basic rules. Every variable that you're measuring in your study should have its own column in the file. Each observation being a patient, for example, should have its own row. So every row in the file is an individual patient. And then each value must have its own cell. And the Excel file is probably the easiest way to think about it. And we'll see an example of that in a second. If you're sending them a research data file, you want to avoid things like highlighting the sheets, multiple sheets, summary statistics mixed in with the raw data. Sometimes people will send a file with data in it from a research study, but they'll also include some graphs in there and things that they've done on their own, which kind of are right in the middle of the data. You typically wouldn't do that because most of the programs that a statistician works with can't read that type of data. It has to be formatted in a very certain way. So a lot of the time, the statistician will advise the researcher about how to collect the data, how to store it, how to code it, so that it's pretty clean from the very beginning, which makes it a lot easier towards the end of the study when it comes time to actually, analyze the data. So here's an example. They call this tidying up the data. So maybe they're collecting the data this way, like on the left here, where they've got this condition variable, 1, 2, 3. They're measuring path size, let's say of a tumor. They've got, left side, and they've got the actual centimeters of the tumor all in the same column. You can't really analyze this data. This might be good for you as the clinical investigator as you collect it, because it's clear to you what you're entering into the file. This could be maybe various different measurements on the same patient, for example. But ultimately, when it comes time to analyze this data, you really have to clean it up. So for example, this condition column, might make more simplified. So here's a column called condition, 1, 1, 1, 2, 2, 2, 3, 3, 3. So you're numbering the condition. And obviously, right or left should be its own variable. So you'll see here R or L has its own column. And actually, you probably would code this numerically. You might say 0 stands for left, 1 stands for right, because it's really better to have numeric codes in your file. So then path size obviously should have its own column, because this is a continuous variable. So if I wanted to measure the mean path size, for example, I need to have a clean column. I can't do that here because I've got all this free text. The L's, the dashes are in the column. You can't do anything with that type of file. So when you clean it up, this might be a version of the file that you might send to the statistician, because now you have 3 separate columns. Everything is kind of recorded in its own column. If something is missing, like this patient down here, and where they say path size is missing with a question mark, again, just leave it blank. So this is path size. The last person just is missing that value, so we leave it blank. This would be something we could obviously analyze. We could take in this column and we could report the mean, the median, and so forth. When you send data to a statistician, you want to make sure you listen to all the HIPAA rules. You want to exclude from the file any identifiers such as name, address, phone numbers, fax numbers, kind of the obvious things that you would leave out of your research file. You obviously want to de-identify it before you send it out to a statistician. So there's actually 18 HIPAA identifiers that you can just make sure you avoid putting in any kind of research data file for the statistician. So when you define your sample, when you're first talking about doing your research study, what do you do? So how do you sample the data? And how you sample it plays into ultimately how you'll do any kind of statistical inference later. So what's the clinical population you're going to study? How will you collect a sample of that population? Are there logistical constraints in collecting the sample? So there's many different ways to collect data for a research study. Many times it's just convenience. You know, if you're looking at a population of diabetics at a given hospital, it might just be a clinic-based study, and you're looking at all the diabetics in your practice seen within a certain time, which is fine. Most research is kind of conducted at that level. Single center type studies are very common. Ideally, you know, there are ways you could do it statistically. So for example, if you have a study population of interest, let's pretend our population of interest is all diabetics in New York City. Simple random sampling would mean you could actually, you know, quantify the entire population of interest and then randomly sample from that population. That way, all the people that are participating in your study, it's completely unbiased because you randomly selected from that population, that underlying population of interest. That almost never happens because obviously we can't quantify all diabetics in New York City and then take a sample of it. It's most likely going to be a convenient sample from a hospital and so forth. But beyond the kind of the foundations of statistics comes from simple random sampling. Theoretically, every person has an equal chance of getting selected to get into your study. So that's the simplest method of sampling if you could do it, but it's probably not that commonly in actual practice. Stratified random sampling, same concept, but you might have a population of interest, but you kind of break them ahead of time into buckets. You know, this might be, maybe you have a population of diabetics, but you're going to stratify it based on various types of medications they received. So you might have 3 different classes of medications. So maybe you break them into these buckets ahead of time, and then you sample from those buckets. So in other words, you can't look at everybody in the population, but if you were able to kind of enumerate them, you could sample from within each of these different classes of medications and have some number of patients in these drug classes in your study, for example. Again, that implies that you have access to the entire population and you can kind of enumerate them. Again, typically probably not that realistic because you're working typically with clinic-based samples. Cluster sampling is also pretty common. Your population of interest might be defined by clusters. So for example, this could be city blocks or maybe schools, and maybe you're going to do a study looking at a specific exposure in a disease, but you're only going to focus on one school or one convenience sample, which would be one cluster, they call it, within a population of interest. So these are just different ways you can actually collect your data for your studies. The statistician also comes in where you ask them, what sample size do I need for my study? So many investigators will say, what do I need? How many patients do I need in my study for me to find what they call statistical significance, for my result to be quote unquote statistically significant? There's really no way to do that in a general way. So typically when you're meeting with a statistician, you have to tell them, what are you looking for? What are you trying to measure? If you're comparing 2 different groups of people, let's say treatment A versus treatment B, what type of difference do you expect between these 2 drugs in terms of your endpoint? It's helpful to have some pilot data that you can bring to the meeting so the statistician can help you figure out the sample size. Because depending on your sample size, that will dictate, will you find something meaningful in your study? So if you're trying to detect a difference between 2 different treatments, let's say the endpoint is reduction in cholesterol, and you're comparing 2 different drugs, what's the difference you're hypothesizing? What difference are you looking for? And that really is driven by your sample size. Will your study be large enough to be able to detect that difference? The statistician can tell you ahead of time how many people you need in your study to be able to detect that difference. but there are a number of inputs that you need to bring to the meeting with you to be able to figure that out. Sometimes the sample size is fixed due to logistics. So you might say, I'm doing a study, I have 150 patients that are available for my study. That's all I have in my clinic that were collected in the past year. So that's what's fixed, that's what's available to me. Then the statistician can kind of work backwards and figure out, okay, with 150 people, what kind of what they call statistical power do I have available to be able to detect what they want to find in terms of their endpoint of interest. There's different ways you can think about it. So we call it, one way is when you're doing a study, we call it a question of description. So a sample size calculation is really based on the precision in estimating your endpoint. So typically this would be an example where an investigator comes in, they have, let's say, 100 patients that they want to look at. They want to measure the prevalence of, let's say they want to measure the prevalence of diabetes among 100 people with hypertension. They're not really comparing anything, just kind of saying I have one group of patients and I want to measure a certain proportion, a certain characteristic. But I need to know what sample size do I need, because when they write up their study, they have to send it to an IRB or to a protocol review monitoring committee. And typically those committees will always ask you to justify your sample size. They're actually pretty obsessed with always having the investigator explain why they're doing 100 patients, explain why they're doing 50 patients. So the statistician can help with that. For a given sample size, the statistician can help frame why that sample size is necessary for a given endpoint. So an example might be an investigator comes in, they say, I plan to prospectively collect data on about 200 consecutive intensive care unit admissions. I expect that about 15% of these patients will develop delirium during their stay based on prior literature. So this is a case where the investigator is telling the statistician, I have 200 patients available that I can study. So it's a fixed sample size. But the IRB, or the Protocol Review Monitoring Committee, is going to ask the investigator, why 200? Will 200 be enough to measure what you want to measure? So typically what the statistician will do is they'll take that number of 200 and they'll give a range of precision. So their endpoint of interest here is how many develop delirium. So it's basically a proportion. What percentage of patients will develop delirium? And they expect it to be about 15%. Again, they would get this from the literature, or this is their hypothesis. So what the statistician can say is, okay, with 200 patients, the level of precision around that 15% at the end of the day when you analyze the data, if it does turn out to be 15% have delirium, the range of precision around that estimate is about plus or minus 5%, meaning they call that a confidence interval, meaning that we expect the prevalence of delirium to be 15%, but give or take plus or minus 5%, kind of like your margin of error. So this is not what they would call a power calculation. This is just a way to tell the reviewer or the review committee, this is the level of precision that I can get around my endpoint with 200 patients. So you're at least telling the reviewer, this is the level of precision I'll have in my study. They're not going to say you can't do the study or not if your precision isn't very good, but you're being upfront about what's available to you with this number of patients. So the statistician typically helps do that for what we call descriptive studies, where we're just kind of reporting out, what is the prevalence of some characteristic in the population. The more common one might be a question of comparison. So, an investigator comes in, they're comparing two groups, maybe those that got drug A versus drug B, and they want to know how many patients do I need in my study to be able to detect some difference in the endpoint that I'm measuring. Let's say it's a reduction in blood pressure, a reduction in cholesterol, whatever they might be measuring with this new treatment. So typically, what we want the investigator to know, the statistician would want them to know, is what's realistic. What sample size can you realistically have in each of those two groups? If this is a single center study that you're just doing at Weill Cornell, for example, what can you really get? Well, we can really do about at most 100 per group over a year. At that point, they're already telling you what the sample size likely could be realistically. Then we can actually look to see, what difference in the outcome can we detect between the groups with that number per group. So we can kind of work backwards to figure out what power do we have, in a sense, to be able to measure what they're looking for. So here's an example. The investigator, the clinical researcher, says they anticipate, retrospectively collecting about 500 patients from, let's say, from the electronic medical record. They know that about 70% of them will have this sensitization allergy, and the other 30% have a mono allergy situation. So they kind of know the breakdown of this different type of allergy sensitivity. So those are their two groups, those that have the allergy versus those that have the sensitivity versus those that don't, or they have more than one versus having just one. The outcome of interest is persistent asthma. If I compare those two groups, how many are going to have asthma at the end of the day? So they're saying a 13% difference in the proportion of persistent asthmatics would be a minimal, clinically meaningful difference they'd likely to detect between the two groups. So they're comparing these two groups. Their outcome of interest is asthma or having persistent asthma, and they want to be able to detect the difference. They're hypothesizing about a 13% difference in the asthma prevalence between those two different types of allergy groups. What can I do with that? How, do I have enough patients to be able to detect that? The statistician would actually run a calculation. So knowing the breakdown of 70-30, which was reported by the investigator, the statistician would say, well, with about 350 patients and 150 patients in each of these two groups, which is just based on that 70-30 split, a chi-square test, which is a very common statistical test you would use to compare groups, will have 80% power to detect a 13% difference between the two groups in the proportion of persistent asthmatics. So in other words, if they think one group will have asthma rate of 70% versus the second group will have an asthma rate of 57%, I'm just kind of making up that difference there of 13%. I will have 80% power to be able to detect that difference with this number of patients per group. 80% power just means if this difference is real, if these two groups really do differ on asthma prevalence or asthma incidence, whatever you want to refer to it as, the study will have about an 80% probability of being able to detect or find that difference. Everything in clinical research with statistics typically wants you to have at least 80% power or greater, but this is limited by your sample size. The more patients you have, the better, the more powerful your study, but typically you want to have at least 80% power. So you'll see that word kind of floating around a lot in the literature. Using a two-sided alpha level of 0.05, I won't spend too much time on that, but this just means, if the difference really does exist, you want to make sure that you can't blame it on chance, that it's a real statistical difference between the two groups. So the statistician can't make this up. You as the investigator have to come in when you're communicating with the statistician. You need to bring a lot of this information to the table. How many patients are available? What's the breakdown of the two groups that you're comparing? In this case, it was very specific. 70% had the poly situation going on versus 30% had the mono situation going on. But more often than not, if it's a clinical trial, it might just be, 100 patients get the drug, 100 patients don't. That's your two groups. And then what are you expecting to see? What's the difference you're looking for in the endpoint of interest? So what do statisticians typically do with all of this? Early on in the design of the study, they will help draft the statistical analysis plan. So as the protocol is being written up, prior to being submitted to the IRB, here at Weill Cornell, we have these protocol review monitoring committees that typically review the science and review the feasibility of the study before the IRB even sees it, the Internal Review Board. So they really look at the science. Obviously, the Internal Review Board looks more at the ethics and, is the study safe? So the statistician typically will draft the analysis plan for that protocol. They will put in, if appropriate, these sample size and power calculations, meaning they will help you justify your sample size, or they'll run this calculation that tells the reviewer, will the study have a chance of being able to define what it wants to look at? If you're trying to detect the difference between groups in some endpoint, will the study have sufficient power to do that? The statistician will put that in the protocol for you. Ultimately, if you're carrying out the study and you complete it, the statistician will help analyze the data. What does that mean? They'll be running different types of statistical tests. They'll generate tables, figures, and so forth. And ultimately, they'll go, ideally, in the best relationship, they stay with you all the way to the end, where they help with the abstract or the manuscript writing. And typically, the statistician will be a co-author on the paper. Because everything we do with the CTSC is obviously supported by the CTSC grant, all the manuscripts that come out of our projects typically will have to cite the CTSC grant, and that gets linked back to the statistician, because the statistician is being funded by the CTSC to help with these projects. So here at Weill Cornell, obviously there's a workload issue, but the way we have it set up here at Cornell is we'll be able to provide at least 6 to 10 hours of free service to the investigator throughout the study in terms of analyzing the data. If the study is funded, the statistician can obviously go on the budget, but depending on what the investigator is doing, we do offer some free services through the CTSC grant, and then we just cite the grant on the paper. Link to the author, which would be the statistician. So things you want to keep in mind when you're designing your research studies and you're and you're asking for statistician input would be, what are the submission deadlines? You don't want to come to the statistician 2 days before the protocol is due. That happens a lot. Abstract deadlines. I have a research study. I need help analyzing the data, but I have to submit my abstract by next Wednesday by midnight. Obviously, you need to give some time to be able to look at the data and analyze it. Many times we'll work with investigators that have submitted a paper to a journal on their own. Maybe the paper was rejected, maybe it's come back and they need to make changes to it. And sometimes the statistician will be brought in after the fact to help address the reviewer comments from that manuscript. So you want to give ample lead time, obviously, if you're meeting with a statistician. You want to meet with them very early on. Ideally, you should meet with them from the very beginning. But obviously, many times they come to you after the fact, and then we jump in midstream, trying to help them as best we can. So you want to keep communicating. The initial meeting with the statistician is just to kind of introduce them to the topic and then what you're studying. You don't want to hesitate to ask any questions until you feel that you're on the same page with the statistician. And this is an ongoing conversation. The statistician will be involved all the way throughout the study, and we'll have a back and forth with the investigator, you being the investigator. So obviously, like I mentioned before, some statisticians will have stronger backgrounds in certain subject matter topics. So you'll see PhD level statisticians trained in a very specific type of statistics that might be, linked to, for example, imaging data, or, they specialize for whatever reason in statistical approaches for cardiology endpoints. So those statisticians might be linked very specifically to a clinical department, and they'll obviously know the subject matter very well. More often than not, the consulting biostatistician, which is typically what we do with the CTSC core, means that we consult on many different projects, many different subject matters. So you have to bear with the statistician to kind of bring them up to speed on the topic clinical topic that you're using, that you're studying. So obviously, you want to have a very good collaboration to have this effective communication between the statistician and the investigator. Patience, respect for one's knowledge base, explaining things in layperson's term is critical to make the statistician feel comfortable, just so you have a good conversation. Personalities will always differ. Sometimes one given statistician might not work well with one clinical research group, so we move people around depending on how the communication is going. It really depends on the situation. So just to review some of the common statistical tests that you're going to see in the literature. Maybe many of you have seen this before, but what do we really talk about? What's the lingo for statistics? We always talk about exposure and outcome. So your exposure is your primary variable of interest that you want to look at, and your outcome is what happens to the people that have the exposure. Then the statistical tests that we choose really depend on the type of data we're collecting. So what are your outcomes? Are they continuous? Meaning, are you measuring change in cholesterol over time? Are you looking at tumor size, which would be like a continuous measure? Are your outcomes ordinal? Do they kind of go from 1, 2, 3, 4, 5? Are they categorical, kind of yes, no type outcomes? Then ultimately, is there any kind of multivariable analysis involved? Meaning, do you want to look at many factors that might predict some type of outcome? So I just want to go over some of the common names that you'll see a lot in the literature. The common statistical test that a statistician will talk to you about. So let's say your outcome of interest is a continuous variable, such as cholesterol level, BMI, a knee rating scale that goes from like 1 to 100. So it's a continuous variable in the sense that it has many different values to it. Hamilton depression score, which I think ranges from like up to 30 or so, for example. That's what we would call a continuous measure. And maybe I want to compare this across two groups. Maybe I want to look at patients that got treatment A versus patients that got treatment B, and I want to compare them on their cholesterol level, their BMI, whatever my outcome might be. So the two-sample t-test, which I'm sure you see a lot in the literature, is a test that compares two independent groups of patients, let's say men versus women, for example, on some continuous outcome. Maybe it's their mean cholesterol, what's the mean BMI, what's the mean depression score for two groups of patients that might have received two types of different medications, for example. The two sample t-test is probably the most popular. The paired t-test is when you're comparing, you have one group of patients, but you're looking at them before and after some type of intervention. So every patient has two values, their pre-measurement and their post-measurement. So the paired t-test looks to see is there a difference between the pre and post in the outcome variable of interest. The ANOVA test is a test where you're comparing the means, but you have more than two groups. So for example, maybe you have, you're comparing three different types of surgery, for example. And at the end of the day, you want to compare the outcome. Let's say the outcome, again, is some kind of a pain score. So I want to look at the mean pain score for surgery 1 versus surgery 2 versus surgery 3. That would be an ANOVA test. So these are probably the most popular tests you're going to see in the literature when your outcome variable is a continuous measure, where typically you would report a mean. You know, what's the mean Hamilton depression score? What's the mean score on the knee rating scale and so forth?
Dr. Christos, I have a question from Ms. Jackson. Are statisticians ethically bound? Are they financially motivated, or are they educationally motivated, typically?
Yeah, I would say they're really not. They really have no, skin in the game. So they have no vested interest in how the outcome will be, which is good. The statistician really doesn't care necessarily about the outcome. So the investigator obviously comes with a research question, and they have a certain hypothesis. But the statistician is completely unbiased because they're going to run the test. Obviously the investigator might want to see the results in a certain way, but the statistician is ethically bound to run the statistical test. Look for all the possible things that could kind of mess up the results or bias the results and discuss it. So that's really the main purpose. Financially, in terms of the salaries they make, it really varies, but typically many of them are on grants. So the funding is obviously relatively minimal. So many work in the academic setting. I suppose if they're working in private industry, it could be a little different, but I'd say most of the people we work with at Weill Cornell are all within an academic medical center and so forth.
And then Larry's, I think, respond to that. This said, despite what you may fear, statisticians as human, as such, some are greedy, some are not interested, some are dedicated, professional, and helpful. As for ethically bound as people, they will maybe as a profession. Statisticians, like programmers, are not called professionals. Premium no, sure. I don't know if I'm saying that right. Might be something they know from
Latin for first will do no harm.
Yes. You can speak, Larry, if you like, actually.
Yeah.
Oh, great.
Go ahead.
Now, making the point that statisticians are human beings. They come in small, medium, and large like everybody else.
Yep.
Physicians are bound, as are accountants and lawyers, that the well-being of their clients is first. Programmers, statisticians, they can destroy society, but they don't teach this in Stats 101. But to concur with our wonderful speaker, they often become a member of a team. Very often they work with the same people over a long period of time, and they do have skin in the game. But like everybody else, you take it as they come.
Yeah, that's a good point. And, many times the statistician will be sitting on a team, and the clinical researcher will want, obviously they have something where they want a certain drug to work a certain way, or they have a certain hypothesis. The statistician will tell them, you can't look at the data that way. We can't code something that way. And they'll be back and forth. The investigators can become annoyed with the statistician because for most often the statistician is pretty unbiased because we really don't care, how, are you going to get a significant result? Yes or no? We're just going to look at the data. But if we see any kind of weird manipulation going on with the data, classic example is investigators will look for, many different associations. They'll have a data set and they'll want to look at all these different things. They call that multiple comparisons, for example. And when you're making all these different comparisons, they call this data dredging, where the investigator is just trying to find anything that jumps out as significant and then publish it. That's actually wrong, because by doing all these different comparisons, you're just really inflating the chance that you're going to find a difference. So many times we'll warn them and we'll say, nope, you have to make a correction, you have to make an adjustment. They might not like it. And if it becomes an issue, the statistician will often have to leave, not often, but they'll have to leave the team or maybe not be on the paper because they don't want to put their name on it if they suspect the statistics are being portrayed in a negative way. My approach has always been, when you're running up the discussion sections of these papers, the statistician needs to be involved so they can see what's being written in terms of the discussion sections. So we'll tell them, you need to include all these caveats because even though you found this result, you did not control for X, Y, or Z. The way the data collected had some limitations to it that really needs to be spelled out in the discussion section of the paper. They might push back the lead author or the investigator. So you do have that situation a lot where, at least as I see it, the statistician is probably more unbiased kind of going in, and they have to kind of fight back and push back against that.
Okay.
If they're going to stay in.
Oh, we have time for one very short story. You'll love this.
Sure.
I'm on one of the advisory panels for the All of Us projects, 1 million patients.
Yes, yes.
And I said, this is a great opportunity to study astrology. Now, my friends take a deep breath. They know me. They know this is a slow curveball. I didn't mean it literally. But when I went on to say is we have 1 million patients and we're going to be correlating and correlating. Something's going to correlate with Thursday.
Yeah, yeah. Exactly.
Absolutely, we'll get something that proves
Yeah.
July or Wednesday. And a large and repeated measures design requires slightly different statistics in an N of 20. And that's what a statistician teaches.
Exactly. That's a great point. Yeah, that's great.
I have another comment from Ms. Scanlon. Question: why research if the SALT for outcome is predetermined?
Sorry, say that again.
Why research if the SALT for outcome is predetermined?
Is the outcome in terms of predetermined in terms of what they think they're going to find? Is that what you mean?
No, let me just jump in real quick.
Yeah, sure.
It's more a comment. Why research if the sought for, S-O-U-G-H-T, if the sought for outcome is predetermined? In other words, if you're not dealing with the null hypothesis and seeking to disprove it, but you are so invested in proving a certain outcome, the research integrity itself can be tainted by the excessive passion of the researcher, not the statistician. So I see the statistician, as you have characterized him or her, as the person who can pull the reins on the horse and keep the study on track. Thank you.
Yep, exactly. Yeah, many investigators will come in and they want to do, they'll have many different questions. They might want to have 3 or 4 different primary aims. We often will rein them back in and we'll say, you really just should look at one question. And they might be invested a certain way in terms of what they think the outcome might be. If there's really a lot of evidence the outcome is going to happen a certain way, they probably shouldn't be doing a clinical trial. But if they're doing an observational study, they can still do it. But we just have to make sure as the statistician that we have an unbiased comparison of those two groups. And we take into account all the variables that might be impacting the results. But yeah, that's an excellent point. So we are typically the people that will rein them back in. A lot of times they expect too much. They only have 30 patients available to them for their study. The most you can do is really write up some descriptive findings and not overstate your findings. So we'll have to kind of advise them on that as well. So that's a good point.
Well, can I step in on that one?
Sure.
There's a sentiment out there that greed is a terrible, horrible, awful thing. Human beings are greedy. It's called motivation. Clearly, there's a lot of greed and a lot of motivation finding a cure for COVID. Somebody's going to make a ton of money. Bear in mind that all research, quality research, goes through a review process with other people who don't have skin in the game, get to step back and say, did you do it right? Did you cheat? Does it get replicated? Don't ever believe any research that's only been done once. Try another lab that wants to prove you wrong. Try to redo it. We're looking at one aspect of a much larger activity.
Yeah, great points. I mean, certainly any kind of small study, preliminary data, you really have to repeat it. You're not going to trust the findings. Also, studies that report null findings, where they don't find what they were looking for, might have been, quote unquote, underpowered, where maybe they did not really do a proper calculation. They didn't specify what they were trying to detect. So it can go the other way. They say something wasn't happening when it really was. So you'll see all these different types of scenarios that could play out.
Okay, and then Mimi Jackson has her hand up. You
Sure.
can speak now.
Oh, yeah, I just wanted to mention why I asked the question, just because my daughter is studying statistics and I pay a lot of attention to the things that she is learning about. She's at Harvard and cross-registered at MIT. And she is learning a lot about statistics, but she presents to me a lot of the things that she learns in class that are
Right.
really interesting. I'm discovering all the ways that statistics can be skewed. You know, you can present something and have like a mathematical proof for why you came up with that, you know, why you came up with that result. And I'm just thinking, unless you have some sort of like ethical requirement, you can prove things that aren't actually true. Well, it's true mathematically, but it's not true generally speaking. Like, well, for example, she had a problem with they give things like, tell us what the average class size is in a certain field, and they tell it in a certain subject matter, and so they tell you about the classes and how many kids are in each class. And well, I'm calling them kids, but they're not kids. Young adults are in each class, and depending on how you want to turn the data, you can come up with different answers. And I thought, that's interesting. So those things, you know, as far as statistics go, I worry that you could enlist a statistician who's smarter than I and gives me results that are possibly not, well, I guess it's not what I'm seeking, but there can be a proof for it. That's all.
Yeah, I mean, it's ideally, when you're designing these research studies, before you know how it's going to go, you should really lay out exactly what you're going to do. So what are the comparisons you're going to make? What types of tests you're going to do? So that you can't kind of change things as you go along. But you're right, there's all these different ways where you could present data to make something look a certain way. You know, many times studies will have missing data, for example. So there's a whole field on, you know, predictors of missingness, where they'll try to impute, you know, what the missing data might be. So you get all these fancy statistical models, which I'm not a big fan of, because at the end of the day, you might get a certain result, but it's really hard to know what it really means in terms of, is that really a valid approach? Versus keeping it more simple, just have a simple comparison across groups early on. So the best way to do it probably is to write it up kind of a priori what you're going to do, specify exactly what you're going to be comparing, so that it is what it is at the end of the day when you get the results. You can't really do too much to kind of present it a certain way. But you're right, you can certainly present it a certain way, do a certain kind of plot to make it look a certain way as well. So more often than not, in my experience, the statistician will kind of push back on that, at least in an academic setting where we're not being, you know, paid to, you know, do outside consulting where we're being asked. But even then, we're going to do it the way we're supposed to do it more often than not.
The other thing is that one of the reasons you teach statistics, and you should be teaching statistics to young physicians as they go through medical school,
right,
is so they can read a journal article, and it's 2 a.m, they got a sick patient, they get off the web, treat or don't treat, and they have to decide for themselves, do they trust that the study was a good study? They all look very sincere. Many of them have been through the review process, not all, but many of them have, but that doesn't guarantee much. Your ability to look at stats and say, did they do the right test? Did they have large enough N? Did the analysis follow from the findings?
yeah,
That's the hard part.
Yeah, and a lot of the departments that we work with that have, you know, that fund some, they cover the salary, or they were able to contribute funding for the statistician. They're kind of embedded within those groups. We'll be involved in the journal clubs. We do a lot of teaching in terms of kind of educating medical students and, like, you know, residents and so forth about how to interpret the medical literature. So we do a lot of that, but you're right. Because reading the studies, you know, you'll see all these fancy statistics, and it's hard to interpret what's really being done. You know, was it the right test? Did they use the right approach? So we do spend a lot of time on that education side as well. Thank you. Okay. So just showing a couple more common tests that you see a lot in the literature. So on the next slide, sorry, let me just move it up. You'll see a lot of these tests listed as well. These are called non-parametric tests, where the outcomes that you're measuring are not really perfectly continuous, such as an ordinal variable, you know, like a grade 2 MCL tear, you know, a pain score that goes from 1 to 5. These are variables where they're not really what we would call continuous, like blood pressure, cholesterol, and so forth. Likert scale variables, like on a survey, strongly agree, neutral, disagree. If you want to analyze the responses to those questions, you can't use the tests that are on the previous slide, t-test, para-t-test, ANOVA. Sometimes people will still use these, but they might be incorrect to use. So these tests are called non-parametric tests, meaning they have less assumptions. So you'll see a lot of these terms in the literature. Wilcoxon rank sum test. And I'm just putting these up here so you're familiar with the terms. And this is still to compare two groups. but typically the variables you're looking at are skewed. So for example, length of stay in the hospital, if you're reporting it, typically you'll see it reported as median length of stay. You don't report mean length of stay, because length of stay tends to be skewed because there'll be a handful of patients that have a very long length of stays. So the median is typically more likely to be presented, like also median income, median tumor size. So these are the types of statistical tests that you would apply to data that is more skewed. Whereas the previous slide wouldn't really work on those types of data sets. So the rank sum test is the same idea of comparing two groups, but we're allowing for the fact that our data might not be what they call normally distributed or bell-shaped in a sense. The Wilcoxon-Stein rank test is the example of a statistical test where you're comparing pre versus post measurements on a patient, but your data is not perfectly continuous. You've got kind of these ordinal type variables going on. And Kruskal-Wallis test is the equivalent of the ANOVA test on the previous slide, but for data where your data is not such that you can present the mean. The mean really only works if your data follows like that classic bell-shaped curve. What's the mean, what's the standard deviation? If I'm comparing, length of stay across 3 different hospitals, typically you would be reporting the median length of stay, but the statistical test used to compare those medians is called the Kruskal-Wallis test. So when you're writing up these papers, if you're not careful and you do the wrong test, typically a statistical reviewer for the journal will catch it and your paper could be rejected, or they could ask you, why haven't you done this test? Getting back to the whole ethical issue, sometimes the tests on the previous slide, these are actually more powerful. It's easier to find differences with these types of tests than it is with these types, because these are a little more conservative because they allow for the fact that your data, is not what they call normally distributed in terms of following the bell-shaped curve, for example. We don't have too much time to spend on that, but the right statistical tests need to be applied to the right data. And your findings, they call that the p-values, for example, which tell you whether or not your result is significant or not, can change if you're using the wrong test. So you have to be careful. Again, the statistician will advise you on the proper test to use. The investigator might push back because maybe they'll like the finding from the 2-sample t-test more than this test here, even though this test is the more correct one. So that gets to the issue where if the statistician doesn't agree, they might have to pull out of the team because the investigator is trying to publish results that really are not correct. So that can happen a lot as well. So again, we're here to advise the investigator on what is the right test to use, statistical test to use. If your outcome of interest is categorical, an outcome like mortality, injury status, yes, no. Maybe you have a pain score that's just kind of broken into categories, 1 to 3, 4 to 5, greater than 5. Presence of disease, yes or no. Those are called, the way we analyze that type of data is with something called the chi-square test. And so here's a quick picture. Let me go over here on the right, where maybe they're comparing what's the relationship between age, broken into these 2 age groups, and the type of surgery that was received. So whenever you have this kind of categorical type data, meaning that you have 2 levels here, 2 levels over here, that would lend itself to what they call a chi-square test, where you're looking for, is there an association between age group and type of surgery received? So they're very common, just to be aware of it. You'll see this a lot in the literature. If your numbers in your study are really small, like if you look at this table over here, very few people, 3, 2, 2, 3, and so forth. Whenever you have really small data, the Fisher's exact test is a test very commonly used when you're looking at categorical data. Both variables are categorical, but your numbers are really small. So just to be aware of, these are the common types of statistics you're going to see in the literature. Just kind of following that, why are we doing this? So for a quick example, what's the relationship between the exposure and the disease? So the whole idea is to figure out, does an exposure increase your risk for disease? And you've all obviously heard of these clinical trial designs, case control studies, cohort studies. So as a quick example, what are we doing in a cohort study? This will kind of lead into the statistics I was just talking about. Maybe you're looking at the relationship between smoking and heart disease. So you've done this big cohort study, and they've got 3,000 smokers in the study and 5,000 non-smokers in the study. And all we're really trying to do is figure out, among the smokers, what's the incidence of heart disease? So in this data, it's 84 out of 3,000. And then in the non-smokers, what's the incidence of heart disease? It's 87 out of 5,000. This is your classic 2x2 table, 2 rows, 2 columns that you might have with a cohort study, for example. And the way we talk about risk is, what is the cumulative incidence in this group? So among the smokers, followed for a certain time period, what's your risk of getting heart disease? And then we ask the same question in the non-exposed group. And typically how you report that would be two separate rates. So among the smokers, the rate of heart disease was about 2.8%, just using the numbers from that previous table. Sometimes they express it as a rate, 28 cases per 1,000 people per year. That's called the 1-year risk of developing disease among smokers. Non-smokers, same idea. This is your comparison group. 87 out of 5,000, which just came from the previous table, which is about 1.74%. These are called incidence rates. You can express it as a percentage, or you can express it as a rate. 17.4 patients or people per 1,000 per year will develop that heart disease. And then typically we take the ratio of these two measurements, which gives us to the relative risk. So this is your classic summary measure or effect size for this type of study. So smokers were 1.6 times more likely to develop heart disease compared to non-smokers. That's called a relative risk. This assesses the strength of the association between smoking and heart disease. It is not a statistical statement. If I wanted to know whether or not this result was quote unquote statistically significant, I would have to apply some type of statistical test, which would actually more likely than not be a chi-square test. But again, you could have this finding, and this is called a crude relative risk, meaning we haven't controlled for anything else. So we try to say, oh, pretty strong relative risk of 1.6. It's possible that the smokers were younger or the smokers were older than the non-smokers. Maybe the smokers were less physically active and so forth. There could be other variables that could explain this association that we're seeing. So again, early on, the statistician can advise you on what would be the variables you'd want to control for. This is a pretty big study. So there's many variables we would want to look at that could be related to smoking and related to heart disease that we would want to control for before we interpret right away this relative risk of 1.6. Because if I fail to control for certain variables, this 1.6-fold increased risk due to smoking could be lower than it really is, or it could be higher than it really is. So again, that's where the statistician comes in to help advise, what should we do to, best estimate this effect, basically. And so just to kind of end with that in terms of a relative risk example, relative risk equals 1 just means the two events have the same probability of happening. Relative risk greater than 1 means you have an increased risk. Less than 1 mean you have a decreased risk. But I just wanted to kind of, we don't have too much time, but just kind of showing basically the types of things you're going to see statisticians typically write up. Many of these estimates will come from models, regression models, and so forth. So for example, on the last couple slides here, multivariable analysis is also obviously something to look out for. So typically any study at the end of the day is going to be looking for the independent effect of a number of variables on a single outcome. So let's say a couple different scenarios. What predicts ACL reconstructions to fail? Ideally, it would be nice to design the study with a very specific primary variable of interest. Let's just pick one. Let's say type of surgery. Maybe I'm comparing two different surgeries, and I want to see, how well do these surgeries do in terms of predicting whether or not these ACL reconstructions will fail. So failure rate is my outcome, let's say. And again, maybe I'm comparing two surgeries. But when I do the study, I want to control for a number of other variables: graft source, extent of rehabilitation, extent of the cartilage injury, and so forth. So this is called a multivariable model because I have to model all these variables to predict the ACL reconstruction. So all these go into a model, and then I can kind of interpret the independent effect of each of these on the outcome. That's called a multivariable model, which I'm sure you all see obviously in the literature. Every study typically, by the time you get to table 3 or 4 of the paper, most likely will do some type of multivariable model because they want to look at a number of variables simultaneously. And again, that gets into, if this is my primary predictor type of surgery, depending on what I put in the model, will influence this final result. So I want to specify things up front before the study is done, before I've collected the data. I'm going to control for X, Y, and Z because the literature shows that these things are important to control for. Then you do your study. You get the estimate for surgery. So does surgery A do better than surgery B? Who knows? But whatever the finding might be, I've controlled for these variables that I selected ahead of time. You do not want to do your study and then start putting variables in and out of the model just to change your surgery variable, which again, as many of you have brought up, could very easily be done because no one really knows what's going on with the analysis. Once it's published, we don't know how the analysis came about. Hopefully it's all written up very specifically with a protocol. So we can kind of get an unbiased assessment of this predictor, surgery status, after we decided to control for these variables from the beginning. We didn't just start throwing stuff in later on to impact that result. And lastly, the different types of multivariable models just to be aware of. If your outcome variable is continuous, multivariable linear regression is the most common modeling technique you're going to see. This means you have a continuous outcome, but you're looking at many different variables simultaneously. Logistic regression is very common. That's when your outcome is binary, such as mortality, yes or no, injury status, yes or no. So you're looking at many different predictors that impact the development of an outcome that's binary, such as did they get heart disease, yes or no? Did they get colon cancer, yes or no? It's very popular to see that in the literature. The other one to be aware of, Cox proportional hazards regression. This is the modeling that deals with survival time. So you'll see many studies with Kaplan-Meier curves, like 5-year survival, 3-year survival. The Kaplan-Meier method is typically the very common type of statistical analysis people do for survival type data, where time to the outcome is important. And when you get into the multivariable setting, typically this is the regression model that is used to look at that. So not getting into the actual models themselves, just kind of showing you when you're meeting with a statistician, these are typically the types of things that will be discussed. We feel that a multivariable logistic regression model is what you need to look at for your data based on your research questions. So that's kind of where we come in to advise on the analytical technique. I think I'll stop there. This is just a link to our Biostats core. So I think many of you can probably, if you ever were doing a research study or if you needed assistance with any kind of research study you might be doing, you can always email me directly or you can submit this form. It's basically through the CTSC. And it basically asks you, what are you doing? What type of study are you doing? What are your needs? Do you need help writing up a research plan? Do you need help analyzing data? So you can always reach me through here and we can assist with if you're doing a specific research project, we can help you with that. Okay, I think I'll stop there and take any more questions. Thank you.
Well, does anyone have any more questions?
I don't see anybody in the chat.
Oh, okay.
I have a question.
Okay.
Sure, yeah, go ahead.
Good morning, Dr. Christos. Great presentation as usual. Is there a reason why R is used in academia more often, let's say, for example, compared to like Python?
Yeah, I think it changes over time. I mean, in the beginning, all statisticians were typically using SAS. On the economic side, any kind of analysis, they tend to use Stata. R now is kind of the new thing. Now you're right, Python is becoming more popular. I'd say all the statisticians we hire now for our department, I'm in the division of biostatistics at Weill Cornell. I'd say all the master's level statisticians that we hire exclusively program in R. Some of them are now starting with Python. I think in the biostatistics world, SAS and R were kind of the main programs that are always being used. Now it's pretty much exclusively R. A number of our group is now learning, we're spending a little more time with Python, like you were saying. You'll see that a little more on the data science side, not so much the biostatistics world, but really they're very similar. These open source programs, my training was typically in SAS, so depending on where you are, it's just really the flavor of the time. Some programs are very versatile, but yeah, I think it's just a preference really. But right now I'd say R is the most popular. But that might change and they might move on to Python down the road.
Thank you.
Sure.
Okay. Jessica said that was an amazing amount of information.
Oh, thank you. Sorry about that. Might have been too much.
Okay, and is there any more questions?
Well, if there's no more questions, Dr. Christos, I thank you so very much for sharing your time with us and giving us that great presentation. Looking forward to hearing more from you in the future. And I thank you. And I thank you for offering to the community the ability to get in contact with you and to get help from you. And I thank you so much for that.
Yeah, for sure. I think we're all part of the CTSC community since you're part of the course. So I think you should have access to the resources just like the rest of us. Again, just reach out to me. We'll just make sure everything is covered under the kind of the umbrella of the CTSC.
Okay.
Thanks.
Okay. Everybody thanks you. And just a reminder, there will be no class next week because it's Veterans Day, but we will meet on the 18th, I believe. No.
Yes.
Yes, the 18th at 10:45.
Yes, and Paul, can we have your email, please? Could you put it in the chat?
Oh, yes. Great point. Let me do it right now.
Thank you.
Okay, I can also forward your email to everybody.
Okay, great. And do you have, do they have a copy of the slides for everyone?
Oh, I could send it to everybody,
Yeah,
yes.
you can send that up to
I could send it to everybody.
Great,
I'll
thank you.
Yeah, I'll send the slides, the email, and this week's set of questions, so.
Sounds good. Okay, thank you.
Okay, thank you, everybody.
Thank you.
Take care. Bye-bye.
Okay,
Bye-bye.
you too. Bye-bye.